paper this afternoon is Predictive Markers of Difficulty of Laparoscopic Splenectomy, Splenic Length, or 3D Analysis of Splenic Volume by Drs. Lengyel and Tavakoladzadeh. I hope I got that right. From the Department of General Surgery, Brigham and Women's. The presenter is Dr. Lengyel. Laser pointer. Advance with the green arrow.
All right, thank you, sir. Good afternoon, ladies and gentlemen. My name is Balazs Lengyel. I'm from the Department of Surgery, Brigham and Women's Hospital. I would like to thank the Society for the privilege of the podium. It is a great honor to be here today. I have no relevant disclosures. Laparoscopic approach was a significant advance in splenic surgery. Imaging and image processing prior to the surgery is generally indicated to assess the area, the spleen, the abdominal lymph nodes. It is often believed that the splenic length is a contributor and a predictor of the difficulty of the laparoscopic case. Many limit the laparoscopic splenectomy to spleen sizes of less than 20 centimeter. However, no reliable imaging methodology or preoperative measurement exists that could determine or properly predict the technical difficulty of LS. So our hypothesis was whether computer-based 3D volume rendering and the volume measurement analysis can better predict the difficulty, a technical difficulty of a laparoscopic splenectomy case than the conventional two-dimensional measurements. We had two groups. In group one, we had 72 non-converted laparoscopic splenectomies with available preoperative assessment provided by Department of Radiology. This generally meant the length of the spleen. And in group two, we had 42 also non-converted laparoscopic splenectomy cases with available DICOM images. DICOM images are the raw, unchanged images coming from the CT. For group two, we used a free source software, Slicer 3D, that's available online to assess the splenic volume with manual segmentation, which I will explain later. Our outcome measures were procedure time and length of hospital stay. We used SPSS and linear and logarithmic regressions to build up our regression model. So as I mentioned before, Slicer 3D is available online. It's a free source software. This is a very user-friendly interface. You can load your DICOM images coming directly for any imaging source. It can be MRI, CT, PET-CT, ultrasound. You can see that the original axial images as well as the pre-formatted sagittal and coronal images are loading to the bottom of the screen. And on the top, you can start segmenting your organs, which is similar to a Photoshop process. You outcircle or draw your area of interest, and this is the end result when the program renders the three-dimensional volume. You can get all different shapes and types of organs of your interest. This is 3 different spleens. And most importantly, the software also calculates and provides surface area and the volume. Using this, and the average segmentation time for providing this was 14 minutes. Using this, we assess the radiology splenic length as a predictor. We try to fit a linear regression model first on the data set of the 72 cases. As you can see, both the R-square and the p-value is insignificant, as well as very low. Also, the logarithmic regression model didn't fit. When we did this with splenic volume as a predictor, the linear regression model fit significantly. However, the logarithmic regression model provided a much better result. Length of hospital stay, neither splenic volume nor maximum length was a significant predictor of length of hospital stay. So our conclusion was that 3D computer-based splenic volume assessment could be a better predictor of OR time in the future compared to the conventional two-dimensional techniques. But further analysis is now being undertaken to confirm this and potentially use it as a reliable predictor in the future. Thank you very much. I would be happy to take any questions now.
Thank you very much. Thank you for keeping under time. We now have almost 7 minutes of discussion.
I'm sorry.
That's great. Couldn't be better. The paper's open for discussion or comment from the floor. I guess from the chair, I think if a spleen is palpable and easily palpable and gets to the midline, that gets my attention in terms of difficulty.
Right.
And certainly if it crosses the midline, it's going to be a lot more difficult. And certain types of splenic pathology make it more difficult. So you obviously haven't looked at splenic pathology, you've just looked at volume.
Exactly.
So how does this really change what you do? What were the indications for the splenectomies that you were looking at, and is this something you think is an important study to do before you embark upon a splenectomy in a patient who has a palpable spleen?
It would potentially help to predict what the operational outcome would be in terms of OR time to try to help plan the surgery prior to the laparoscopic approach. It's a very good point, by the way, that we eliminated the hand-assisted approaches and we didn't look at the certain pathologies before. And the spleen is one of the organs that has the biggest variety of different pathologies before the operation.
I know that when I'm teaching splenectomy, my sphincters are never quite as tight as when the resident is trying to dissect around the vessels and or close to the splenic hilum. Of course, getting a bleeder on the hilum is the disaster you don't want to have happen. From the floor.
Abderrahmane Mary from Abu Dhabi. Thank you for a nice presentation.
Thank you.
There's been a study before looking at the length of 21 centimeters, and they decided that if it was longer, they would do it hand-assisted. Is this something that you think that you'd consider in the future for large volumes of the spleen, or?
It would actually be, thank you very much, it's a very good question. It would actually be interesting to now try to split up the data set and then look at if less than 20 centimeter and predicting that as a difficult case, or less than 15, or between 15 and 20, or above 20. There would definitely be a big potential.